Welcome to this explainer. I'm absolutely thrilled you're joining me today. We're about to take a really fascinating journey through some pretty dense medical data, but we're going to frame it as a logical, anatomical descent straight down through the human body. Now, before we even get to the organs, we have to talk about the true enemy when it comes to diabetes. It isn't just the hyperglycemia itself, it's time. It's this ticking clock of elevated blood sugar that just systematically breaks down the body's microvascular and macrovascular systems. By the end of our time together today, you're going to see exactly how this chronological damage unfolds, literally from head to toe. Okay, let's dive right into this roadmap. First up, metabolic memory. Then we'll go top down into microvascular complications in the eyes and kidneys. Section 3 is all about neuropathy and cardiovascular risk. After that, we hit the diabetic foot. And finally, we'll wrap up with the unique infections and skin manifestations. So, starting us off with Section 1, metabolic memory, also known as the legacy effect. Before we look at specific organs, we absolutely have to understand this overarching rule of time, because past glycemic control literally dictates future clinical reality. To really get this, let's look at two massive landmark trials from the data. We've got the DCCT for type 1 diabetes and the UKPDS for type 2. Both of these trials pitted intensive glycemic control against standard control. And yeah, driving that A1C down into the low sevens gave us huge reductions in things like retinopathy, albuminuria, and neuropathy. But check out the UKPDS findings for type 2 diabetes. While managing blood sugar was obviously vital, it turns out blood pressure control actually provided even greater overall benefits than just glycemic control alone. I mean, lowering blood pressure gave these incredible 32 to 56% risk reductions for death, stroke, and microvascular endpoints. That's huge. And this brings us to a massive, absolutely crucial clinical concept from our sources. It's called metabolic memory, or the legacy effect. Basically, it means that a solid period of good glycemic control early on in the disease gives the patient lasting protection against complications, even if their control goes totally off the rails years later. Both of those trials we just talked about proved that early intervention literally rewrites the body's future, most likely through epigenetic changes. It leaves a protective legacy that lasts for a decade or even longer. Talk about a massive exam pearl, right? And this brilliantly illustrates just how quantifiable the power of taking early action really is. The UKPDS data shows us that each single solitary 1% drop in HbA1c leads to a staggering 35% drop in microvascular complications. Every fraction of a percent matters deeply when we're talking about the longevity of your patient's organs. It's just wild. Moving right along to Section 2, eyes and kidneys, focusing on that microvascular damage. All right, let's get into our anatomical journey, starting right at the top. And the sources present a bit of a paradox here. Imagine you've got a patient with established diabetic retinopathy. You start them on an intensive therapy, let's say a GLP-1 receptor agonist, and you rapidly normalize their blood sugar. So what happens to their eyes during those first 6 to 12 months of really improved control? Do they just immediately get better? Well, the answer in the text is actually super counterintuitive. You get what's called paradoxical worsening. Yep, during those first 6 to 12 months of rapidly improved blood sugar, established retinopathy might actually get worse temporarily. This is such a critical clinical warning from the literature. Before you start intensive therapy, especially with things like GLP-1s or pancreas transplantation that tank blood sugar fast, the data is crystal clear. You have to warn your patients that their vision might take a temporary hit before it finally stabilizes. Now, moving down to the kidneys, let's trace the natural history of diabetic nephropathy. Notice how the kidney kind of paradoxically overworks right before it fails. In the first few years, you actually see glomerular hyperperfusion and an increased glomerular filtration rate, or GFR. Then, right around that 5-year mark, the GFR drops back to normal, but silently under the radar, the basement membrane is thickening. The real turning point is stage 3, which is microalbuminuria. That's your very first detectable sign of nephropathy. If that goes on to progress to marked albuminuria with a decreased GFR, well, at that point, the pathologic changes to the kidney are pretty much irreversible. So how do we actually protect these kidneys? With ACE inhibitors or ARBs, right? Well, the guidelines highlight a massive exam trap right here. RAS inhibitors absolutely do not prevent diabetic kidney disease if the patient doesn't already have hypertension and doesn't have albuminuria. You cannot just give them prophylactically. And even more importantly, and I literally cannot stress this enough, the sources say do not combine an ACE inhibitor with an ARB. Dual RAS blockade gives you absolutely zero added benefit, and it severely spikes the risk of hyperkalemia and acute kidney injury. Just don't do it. Okay, section 3, neuropathy and cardiovascular risk. Let's look at the nerves and the heart. Continuing down our anatomical timeline, let's hit the nervous system. Now, what's really interesting here is the pupil. This is a classic distinction in the material. If a diabetic patient rolls in with a cranial nerve 3 palsy, diplopia, ptosis, you have to look at their pupil. A diabetic CN3 palsy is an ischemic issue. That means the pupil motor fibers on the outside edge of the nerve are spared. The pupil stays normal. But if you're dealing with a posterior communicating artery aneurysm, that's compressive. Those outside fibers get crushed first, which gives you a dilated or fixed pupil. So that one single observation is what distinguishes a benign diabetic complication from a literal life-threatening aneurysm. But it's not just isolated nerves. Diabetes absolutely wreaks havoc on the entire autonomic nervous system. Cardiovascularly, you're going to see reduced heart rate variability and resting tachycardia. Down in the gut, gastroparesis causes delayed emptying. Because of that, you really want to avoid GLP-1s and opioids since they just slow things down even more. In the bladder, diabetic cystopathy causes urinary hesitancy and incontinence. But honestly, one of the most surprising takeaways from the text is that erectile dysfunction is frequently the absolute earliest sign of diabetic autonomic neuropathy. It is so often the very first red flag that the whole nervous system is becoming compromised. And when we talk about cardiovascular risk, you have to remember this staggering fact. A type 2 diabetic without a prior myocardial infarction has the exact same ASCVD risk as a non-diabetic person who has already had a heart attack. Let that sink in. That fact heavily dictates these super aggressive statin goals. If they have diabetes plus ASCVD, they need a high-intensity statin, aiming for an LDL of under 55. If they're 40 to 70 with diabetes but no ASCVD, they get a moderate-intensity statin. And hey, if their triglycerides are soaring over 500 even with a statin, you've got to add icosapent or fenofibrate to protect that pancreas. Moving on to Section 4, the diabetic foot and lower extremities. Continuing our descent, we finally reach the lower extremities, which are home to some really devastating macro and microvascular overlaps. The text outlines how a diabetic foot ulcer doesn't just spontaneously happen. It builds up through this terrifying clinical cascade. Step 1. Sensory neuropathy causes a total loss of protective sensation, meaning trauma just goes unrecognized. Step 2, motor neuropathy kicks in and alters the mechanics of the foot, creating claw toes and intense pressure points on the metatarsal heads. Step 3, autonomic neuropathy stops the foot from sweating, which leads to dry, cracked skin that is basically an open door for bacteria. And finally, Step 4, peripheral arterial disease deprives that new wound of the blood flow it desperately needs to heal. It is literally a perfect storm. So, to manage that perfect storm, the guidelines lean on 5 core evidence-based interventions. First, offloading the weight. Second, surgical debridement. Third, physiologic wound dressings. Fourth, revascularization if arterial flow is poor. And fifth, getting them on the right antibiotics, and you absolutely must cover MRSA and strep in severe cases. Also, just a quick clinical pearl here. If you need to figure out if that ulcer has gone all the way to the bone and caused osteomyelitis, a simple probe-to-bone test is highly predictive, but an MRI is going to be your most specific imaging modality. And finally, Section 5, infections and skin manifestations. All right, let's rapid fire through some severe pathogens that just absolutely thrive in a hyperglycemic environment. Because diabetes compromises immune function, there are certain severe bugs that prey almost exclusively on these patients. For example, rhinocerebral mucormycosis is this rapidly progressive, life-threatening fungal infection that is very closely associated with diabetic ketoacidosis. Then you have malignant otitis externa, driven by Pseudomonas, which aggressively attacks the soft tissue and bone of the ear canal. And incredibly, emphysematous or gas-forming infections of the kidneys or gallbladder, those are almost entirely exclusive to the diabetic population. You just don't really see them anywhere else. Externally, though, the skin acts like a literal billboard for the patient's metabolic state. Contrasting these visual clues is super helpful. Diabetic dermopathy, which are those circular, hyperpigmented spots on the shins, is your most common skin manifestation. Then you have necrobiosis lipidoica, which shows up as a plaque with an atrophic, often painful ulcerated center, and you see this mostly in young women. Acanthosis nigricans, those velvety dark plaques on the neck or the axilla, well, that's your glaring, undeniable marker of severe insulin resistance. And lastly, bullosa diabeticorum presents as these shallow, spontaneous blisters right on the lower legs. As we wrap up this explainer today, I really want to leave you with a final provocative thought from the material. We started off by discussing the ticking clock and metabolic memory, right? The proven fact that early glycemic control literally alters epigenetic expression and gives a patient a decade or more of legacy protection. So when you're looking at a newly diagnosed diabetic patient, are you just treating their high blood sugar today, or are you actually treating and preventing the amputations of 2036? Keep that perspective front and center. Thank you so much for exploring the source material with me today.